Welcome to the Healthy Matters Podcast with Dr. David Hilden, primary care physician and acute care hospitalist at Hennepin Healthcare in downtown Minneapolis, where we cover the latest in health, healthcare, and what matters to you. And now, here's our host, Dr. David Hilden.
Hey, welcome to episode 6 of the podcast. I am your host, Dr. David Hilden, and today we're talking about men's sexual and urologic health. You know, one of the great things about the podcast medium is you can learn about things you might not feel comfortable talking about. And if you're listening today, and maybe you're thinking, I've wondered about this but never said it out loud, just know you're not alone. Erectile dysfunction, testosterone issues, urinary leakage, these are incredibly common, and yet they're some of the hardest things for men to talk about. The good news is these are medical issues, they're treatable, and they're often connected to overall health in important ways. To help us walk through what's normal, what's not, and what to do about it, I'm joined once again by urologic surgeon Dr. Travis Pagliara. Travis, welcome back to the podcast.
Thank you, Dr. Hilden.
It's great to have you here. Maybe you could frame the conversation for us. We're talking mostly about men's urologic health today, but many men and their partners feel uncomfortable discussing sexual health. Why is having this conversation so important?
So I think there's a couple ways you could approach it. First, you could look at it from the physical side. Obviously, men care about sex. They care about their own urinary health, but they might be uncomfortable talking to their partner. But there's actually studies that show that they want their doctor to ask them about it. It's like you may be ashamed about it, you may be afraid to talk about it, but you want to be asked. So if it's a doctor listening to us today, ask your patient. You'll have higher satisfaction scores. And if you're the patient, don't be too afraid to bring it up because the doctor's there for you. Even if they don't know the answer, they know who to refer you to. These conditions, they're going to cause stress in your marriage. They're going to cause stress internally. There's signs of depression that are associated with all sorts of things we're going to talk about today, from incontinence, from erectile dysfunction, from low testosterone, decreases in quality of life, and actual physical manifestations of these problems that can lead to a shortening of your life even.
What a great way to frame it. And I've already have a take-home point. I am a doctor. I am sitting there with a lot of men in a clinic room, and I have to remember to ask. They really do want to talk.
No, absolutely. If they feel like, I'm at a place where I should feel safe, and if they feel like their doctor can ask them this question with that little bit of confidence of, look, I'm asking you this for good reasons, they feel like, wow, this person really wants to help me.
Nice. Yeah. Okay, so let's normalize the topic by talking about how common are these issues.
Okay, sure. We have a couple different topics. So, let's touch on it first with incontinence. It's pretty rare in men, okay? It's most common, though, after having prostate cancer treatment, surgery, or radiation. In those men, 10% of men who have had treatment for prostate cancer will end up having some form of incontinence. Most common is stress incontinence, meaning the type that you get when you cough, sneeze, laugh, shovel snow, that sort of stuff. Well, considering we treat about 60 to 150,000 men a year, there's a lot of men out there who have this problem. When we talk about erectile dysfunction, now the numbers start to really, really climb.
Really common.
Really common. If you look at some studies, they say men over 40, 50% of men have experienced it. Now, it starts to increase. It's not like all men in their 40s, but it starts to increase dramatically, exponentially by the decade. So every 10 years you go up, those numbers are going to increase. I've seen a study that said 80% of men at 80 years old have erectile dysfunction. So it really does climb rapidly. And then for hypogonadism, we're still trying to gather the numbers on this. There's Hypogonad, you're right, exactly. Low testosterone, low T.
Low T, as you maybe have heard out there in the community. Hypogonadism, that's the medical term.
That's the medical term for low testosterone, which we're all being targeted with ads nowadays. I don't think I can, and it's probably because of my profession and what I do, but I swear that the ads on the internet target me and tell me and talk to me about low T every day, right? And I'm sure a lot of men out there in their 50s and 60s are getting those same targeted ads. The number of prescriptions for testosterone for people with prescriptions in the past few years has more than tripled. Talking about a huge increase. Now, not everybody's following the proper guidelines with those, but the numbers are really staggering. You can read all sorts of different options in terms of answers, but it's 15 to 25%, up to 50%. I've read studies all over the board.
So you're a urologist. Before we get into these topics individually, what the heck do you do?
Yeah.
What is a urologist?
Great. So
I think I know, but help us out.
I have 2 kids, and my 7-year-old knows of me as a bladder doctor, which is almost great. I more like colloquially we say that I'm a surgeon of anything that touches or makes pee. That's another way to put it.
Did you grow up thinking that that's what I want to do? I want to be a surgeon for the naughty bits.
Yeah, the stream team. That's right. No, there's a whole lot of names. I never thought I would be, but here I am. And I love it. So if you think about it, we are the surgeons who did a surgical residency, meaning 5 more years of specialized training on the kidneys, the tubes that connect the kidneys to the bladder, and then the genitalia. So anything in that area, we're kind of the surgeons, the specialists of it.
Got it. So Travis, talk us through like a typical man comes in with you and how do they frame these issues? Do they usually say, I'm having trouble with my sex life, I'm having trouble with my urinary life? How does it usually present to you?
Good one. So we have a couple different options. Sometimes we get patients referred to us because we are more of a specialty center and there's a lot less urologists than there are internal medicine doctors. So a lot of it's a referral basis. So they come to us with a problem in mind. They might have an elevated PSA, which is the screening number for prostate cancer. And then while they're there, we check on all their issues. And, we happen to say, we're dealing with that prostate cancer stuff. But at the same time, do you have any issues with erectile dysfunction? Do you have any issues with incontinence? And then sometimes people are a little shy around and beat around the bush a little bit. And they might say, you know what, me and my partner are having some issues. And that's, my key. I think what you learn from doing years of clinic in urology is all you want them, if they just open the door the littlest bit, you're like, I got it from here.
Yeah, you know where this is going.
I know how to take you down the journey of this conversation. We're going to be fine, and then you can just make them feel comfortable. Because the thing they're most nervous about is that I'm going to be awkward. So I think when I can look them in the eye and talk to them directly and say like, hey, look, yeah, you're having ED. It happens. Yep. It happens to this many men. And they're like, what? That many people have this? Yeah, you're not alone in this. Don't worry.
And it is a little bit of a window into men's overall health. They might come with you with erectile dysfunction. You find out about a whole bunch of stuff going on in their life, or their urinary incontinence, and they're worried about cancer. So there's a lot of overlap with all that.
And just to even take that a step further and put something concrete to it. So the arteries that give you erections, they're a third the size of the arteries in your heart. So if someone has atherosclerosis, if they have diseases of their blood vessels that we get from high lipids, we get from having diabetes, the general things we think about causing heart disease, well, guess what? They affect the penis on average 5 years before they're ever going to affect the heart. So we used to call erectile dysfunction the canary in the coal mine of heart disease.
Oh, that's fascinating.
And there's tons of data, especially in the diabetic community where it was really well studied, that before having a heart attack, ED predates it by 5 years. So really, you can save a life. There was a great article in the 90s that somebody wrote and said how to save a life in a urology visit for ED.
Look into the erectile dysfunction before they're having their heart attack.
Yeah. And we have more we can talk about this with the low testosterone too. So I'll wait to bring it up.
Okay, so although we did a whole episode on erectile dysfunction 18 months ago or something, and listeners, I do encourage you, go back through the archives, find the one for Dr. Pagliara and I where we talk about ED. But we're going to touch on it briefly here today, if we could. How do you define erectile dysfunction? When is it a problem?
Yeah. The funny thing is, it's a vague definition of whenever it's a problem for you.
Exactly. That's what I was going to say, because that's pretty subjective, isn't it?
It is, absolutely. So if it's a problem for you, we're happy to make it our problem too and help you work through it. Sometimes it is just psychologically, we're like reframing what's normal and maybe this shouldn't be a problem for you. And other times it's, you actually do have a problem and we need to address it and, give you the whole litany of the options that we talked about last time for fixing it.
Yeah, because you said it's very common in men over 40 and then even gets more as 50. And then you mentioned 80-year-olds. So a lot of people are probably going, well, yeah, you're getting older. That's what to expect. So is it normal? I mean, as you age, it's common as you age, but is it normal? When's it a pathology?
Yeah, that's a good question. And I think it depends on what the underlying problem is. So like when people come in for it, I always screen them and tell them, hey, we're going to check your testosterone level and we'll get into that. We're going to check to see if you have high lipids and send that to your primary care doctor to make sure they're addressing it. We're going to screen you with an A1C, which is a test for diabetes, and find out if you had undiagnosed diabetes. I found people who have diabetes because they came to me for ED. They didn't have good primary care follow-up, but I was like, hey, look at that. We might have just saved your life. So,
yeah, exactly.
Yeah.
So can you talk to us just briefly, what are the causes of erectile dysfunction? I guess that might actually mean, tell us what causes a normal erection and then what can go wrong.
Absolutely. So it's way more complicated than people think. I always tell my patients that erections start in the brain. Okay. So you have to be in the right headspace. And that leads to the first area, the first category of problems, which is psychogenic erectile dysfunction, meaning you're just nervous.
It's between your ears.
It's between your ears, all right? Supratentorial, it's up in your head. You just have a problem where you're thinking about work, you're nervous, are you going to be able to perform, you're with somebody new, all those things that can cause stressors. That's the number one cause of ED for people under 40. So when somebody walks into my clinic and they're 25 years old, that's exactly what I'm focusing on. I'm saying like, look, tell me about your stressors in your life. You start a new job? Do you get fired? Got a new girlfriend, new boyfriend? What's going on? So we go down that pathway. Beyond the brain, it has to travel a signal via nerves. So you can have a nervous issue. That can be a source of problems. From there, it has to hit the arteries, which open up and bring more blood flow in. And then you can think about an arterial problem. The other source, though, up high is in the brain would be like your libido. So that's where low T can kick in. If you do have low T, low energy levels, it could be a cause of erectile dysfunction as well. So what's normally supposed to happen? Kind of that pathway, brain, nerves, blood flow. But if it doesn't, any of those steps
a number of places things could go haywire. So let's talk about what I do want to focus on in this episode a little bit is testosterone and its role in men's sexual health. So start us out. Frame that. What is testosterone? When's it a problem? Let's get into that.
Absolutely. I think I'm waiting to see a good summary, but testosterone research has been probably one of the most quickly expanding areas in urology in the past 10 to 15 years. 20 years ago, it was barely talked about, and now it's everywhere.
I got to be honest, in med school, I think we had about a half-hour lecture on it.
That's it, right?
25 years ago. I don't think there was tons on it.
Right. But now you'll see that there's 10 more ED or T clinics popping up around the Twin Cities, and they all frame themselves as men's health clinics. They're all really focusing on checking testosterone levels. So what is testosterone? It's the male hormone. It's only produced by one thing in your body, and that's your testicles. And your testicles really only have two jobs. They make testosterone and they make semen. That's it. If one goes wrong, they usually both go wrong. So if you're having problems with infertility, you probably have low testosterone too. If you have low testosterone, you're probably infertile too. There's a good chance at least. But the way we find out if you have an abnormal testosterone level is a blood test. Now it has to be drawn in the morning because where we determined what normal was all based on curves of thousands of people based on morning tests. And it's interesting, like this molecule is fascinating. So in our bodies, we see this peak of it in the morning, and then it starts to decline around noon, and it goes down. And then you get a very small second peak in the afternoon.
I was wondering why this is.
Yeah.
Because I see patients often in the afternoon, and if we're talking about testosterone, I go, oh, sorry, buddy, it's 3 in the afternoon. It's not a great time to check it. I'm supposed to check it at 8 a.m. Why is there a variation during the day?
But think about it back to the day of like hunters and gatherers. This is what I like to do. I like to go back to this idea of, all right, what drove us to get out of the caves and go hunt? It was testosterone. Right? What got us up and moving?
I got up really early this morning to shovel snow.
Yeah.
I wonder if that was
your
because
testosterone's great, Dave. It's so good.
Oh, good to know. It's really reassuring.
No, but I think that there's something to this that goes, we could go back to we could anthropomorphize it all the way back to the very Stone Age. But really, this is what we know. It's high in the morning, and that's when we have what is our normal level. So that's what we have to base it on. So if your doctor says, oh, I can't check it now because it's 12 or 3 o'clock, they're doing it for good reason. They're not just trying to push it, kick the can down the road. They're saying, look, you need to have this check before 11 because if I check you at noon or 1, everyone's going to look low. Yep. And we're not going to have a good
You're going to look low because it's supposed to be lower, and the reference values were done at 8 a.m.
Right.
That's basically what it is. So tell me about symptoms.
Okay, symptoms.
What symptoms? Now, here's what I'm going to tell you, Travis, what I often see. I have a guy who's about 55 years old, and he comes in, I'm tired.
Yeah.
He doesn't even get so far into the erectile issues yet. Is that a symptom, or what are the common symptoms of low testosterone?
Great. There's actually a questionnaire out there called the ADAM questionnaire, and you can look it up. But in general, things like, yes, I'm tired. I just feel like I have no pep in my step, no energy levels. That's probably the most vague of them all because, as you know,
it is kind of vague because there's like 38 other causes of that too.
Exactly. Right. But this is the one that I think is the most often overlooked. This is one where people just say, "Well, your thyroid was normal, and I don't have anything else." And you don't have any.
That's a true
disease.
statement. We check thyroids all the time when people are tired.
Right. Exactly. But this one can be that hidden one that you haven't checked. So they're tired. They have a low libido. They just feel like I don't even want to have any sex anymore. I just don't don't even have any drive at all. You're falling asleep right after you're eating is an example of a symptom. Why that is, don't exactly know. But I don't think
really?
Yeah, literally, you have dinner and you're like, yeah, I'm just zonked. I fall right to sleep immediately. It's one of the list of the questions that we ask people for.
Could have been the 2 glasses of wine that you had with that
could
jumbo
definitely do it
steak.
too. Yeah, that could also do it. Yeah, your meat sweats and your exhaustion, right?
But after exhaustion after eating.
Pathologic fractures. So people have loss of bone density. If you're like breaking a bone and you're like, well, I've never broken a bone before. That's odd. That's one thing to check. Loss of height is a weird one. I haven't actually seen anybody come in for that, but it's another sign of it. People who have chronic disease states, so people who are chronically HIV positive, people who are diabetics, people who are morbidly obese, it's actually now indicated just to check them automatically because the chronic disease state of inflammation can suppress your testosterone levels. Aside from that, ED is another one. Heart disease is another one. And this is one of those really fascinating factors. If you look into the idea of testosterone replacement, you're going to see all these things pop up on the internet about, increases in heart disease or heart attacks and prostate cancer. In truth, that we have very large studies that have meta-analyses where they look at all the papers that are out there, right? And they try to summarize what's the actual answer? What is the truth of this? And they found no correlation between the risk with prostate cancer, no risk with the heart attacks. But what they have now found is that low testosterone is an independent risk factor for heart disease. So the reason why this is tricky, it's hard to study will people get heart attacks on testosterone replacement because of the age group.
Yeah, because it's so common. You might get it anyway for a number of reasons.
Exactly.
You have other risk factors.
Yeah, the most common age that men are going to be put on testosterone replacement is in their late 50s and 60s, even 70s.
Yeah, right when heart disease starts showing up in men.
Right. So that's why these studies are really faulty. They're never able to prove, you look at one study, it says men on testosterone get heart attacks. You look at another, it says it decreases the risk. So they looked at it differently, and they just found out, all right, men who are on testosterone and men who weren't, who has the higher incidence of heart disease, like the atherosclerosis, looking at calcium scans and all that other stuff. And they found it is an independent risk factor.
So having it low is actually dangerous.
Low testosterone is dangerous.
So you mentioned all these signs and symptoms for why you might have, or where your doctor should look into low testosterone. But isn't it just normal as you age that it drops? Or is this, are these things, did it start at birth, or did something happen later in life, or is it just a continuous drop as we age?
Now, good point. There are, of course, anomalies and genetic things, chromosomal changes, things that you're born with, right, that can cause you to have low T forever. They usually present in their 20s, and we're trying to figure out why they've had infertility issues. That's a
common way they show up.
They show up, and they're like, actually, you don't have any sperm, and you don't have any testosterone, and they may have never known. They might have been gone through puberty even in a pretty normal way. There's all sorts of things. But for most men, it's not supposed to just dramatically decline. Really, the testosterone level should stay above 300 even as we age. So when testosterone, and this is what our National American Urologic Association guidelines tell us, is that as long as it's above 300, you don't need replacement. But when it gets below, it's pathologic, meaning it's
throughout your life?
Throughout your life, yeah. Now, here's the thing. If somebody comes in and they're 70 years old and they tell me, I've had this change, I feel different, I don't have drive, I don't have energy, and they come in and their testosterone's 250, you wouldn't just do it to treat the number alone. What we do is treat the symptom and the number. And then they tell me they've got all these symptoms and their number matches, I'd say, fine, let's treat you. If you want to, understanding the risks and the benefits.
That makes sense. Before we get off the signs and symptoms and the levels of testosterone, what about is there a correlation between morning erections and testosterone?
Yes.
Many men might know this since you were 9 or 12 or 14 and throughout your life. Is that a real thing? And if someone is in their 20s, they're having trouble conceiving a child with their partner, would they have known? Would they have had any clue based on things such as that?
Absolutely. That is another sign. If somebody comes in and they say, I'm not getting erections naturally in the morning, I'm not getting them at nighttime, that's absolutely, like we ask, do you get nocturnal erections? And there are tests for that. But then also, are you getting them in the morning when you wake up? And if they're not, it is a sign that they could have low T as well.
Great. We're going to take a quick break now. We are talking with Travis Pagliara. He is a urologic surgeon, and we are talking about men's sexual health. When we come back, we're going to talk a little bit about urinary incontinence and then about treatment options, particularly for low testosterone. Stay with us. We will be right back.
When Hennepin Healthcare says, "We're here for life," they mean here for you, your life, and all that it brings. Hennepin Healthcare has a hospital, HCMC, a network of clinics in the metro area, and an integrative health clinic in downtown Minneapolis. They provide all of the primary and specialty care you'd expect to find, as well as services like acupuncture and chiropractic care. Learn more at hennepinhealthcare.org. Hennepin Healthcare is here for you and here for life.
And we're back talking about men's sexual health. So, Travis, let's touch a little bit, if we could, about urinary incontinence in men. How common is that?
Well, like we said before the break, it's mainly in men who are going to have a result of treatment for prostate cancer or for big prostates, BPH. Primarily, though, it's going to be after prostate cancer. So to touch on those real quick, men either get radiation or they get surgery to remove or try to destroy the prostate tissue that has cancer in it. And as a result, about 10% of men after 1 year are going to have permanent incontinence. And that means that they leak and have to wear pads or diapers, at least a pad a day, sometimes many diapers a day, every time they cough, sneeze, or just do anything that involves a stress.
So that's a bummer. Do men know that before they're, because you treat prostate cancer too.
Right.
Is this conversation usually had with men that there's at least a chance?
Yes, and it absolutely should be in every informed consent discussion about treatment, because to say it, when I said it happens at a year, well, that whole year beforehand, it's much, much worse. So almost everybody leaks for the first few months, and we're talking
after their treatment.
After their treatment. Yeah. And so they have to wear these sorts of absorbent products. And then it starts to get better as you regain strength and you learn to kind of coordinate your muscles around the area to hold it back better.
Why is this? And I think it's something to do with the anatomy of where the prostate is.
Totally, absolutely. So it's one of two things. It's either like destruction of the nerves or the actual tissues themselves. So there are two sphincters. Sphincters are like your mouth. It's a circular muscle, right? There's one at the top of the prostate where it meets the bladder, and there's one at the bottom of the prostate. That's the one that, for the guys listening, if you were standing at the urinal and you wanted to stop peeing without using your hands, you'd squeeze that muscle.
Yep.
Women would call it kind of like a Kegel exercise also. You squeeze that pelvic floor. Well, when you have prostate surgery to remove your prostate, the nerves get shocked, the muscles themselves can get damaged, and so you can no longer make that sort of squeeze. And by doing so, without that ability, you start to leak. So you lose the little lizard brain sphincter that we have. That's the one inside of the bladder neck. Our body actually just keeps that tight all the time.
Keeps it tight.
And that one gets destroyed by the surgery because we have to disconnect the prostate from the bladder and then sew the urethra back to the bladder. And the other one just loses some control and gets kind of shocked after surgery.
So that's relatively common. 1 in 10 is relatively common, a 10% chance of some urinary incontinence, and it's mostly after prostate cancer treatment.
Mm-hmm.
Okay, let's talk about some treatment options, mostly for low T. Low testosterone is what we're talking about now. First of all, before we get into treatment, I guess I should ask you, how do you get tested? You said it's a morning, is it just a blood test?
Yep. So to qualify, most insurance companies and then most guidelines, they want you to have 2 tests. So the first one we do is just a screening blood test, and it just has total and free testosterone. The reason we say total and free, okay? So total is the amount of testosterone in your body, but the free is what's actually active. And there are a lot of other molecules in our blood that bind up the testosterone. And so if it's really bound up, it doesn't do you any good.
It kind of takes it out of active.
Exactly. So you need to get both numbers. Then if that's low, then a week later, you can have a secondary test. And with that one, we add on a whole bunch of other hormones, FSH, LH, prolactin, estradiol, TSH. We'll test all the other stuff too.
All these hormones, yeah.
Right. So we throw a bunch of other, abbreviated hormones at you to try to get those tested to rule out everything and then make sure we don't have, any really dangerous causes. Because there are some really rare things like tumors in the brain that can actually cause low testosterone. So we just want to rule those things out. That's why we check what's called prolactin.
So after the second set of tests, your doctor tells you your testosterone levels are low. Mm-hmm. What are your options?
So now this is where you've probably seen lots of advertisements because the world is your oyster.
You've probably seen on TV, if you're a TV watcher, low T. You've seen it in 89-point type on the TV screen.
Absolutely.
Because they have a solution for you.
So,
but there are a lot of really good ones, are there
really
not?
are.
Yeah,
And
there
honestly,
are. Yeah.
the world of the pharmacology of this has really changed just in the last 5 years. Like, we didn't have an oral option really 5 years ago that was safe, and now we do. But all of these have a trade-off, okay? So we're going to try to touch on these. We can start with just injectables in general. So longest acting injectable you have, we place these little pellets. They're made of testosterone out into the upper buttock fat. So out into your like hip sort of area. You come in, it's a 5-minute procedure, almost no pain, and you have it, and it stays in there for 4 to 6 months, just slowly dissolving in your body, always giving you that steady state. Okay? You'll always have the same amount of testosterone in you. And it's great. Next, you can say, well, I don't want to have a procedure, or procedures are expensive, or I don't like needles. And
Is it like a little pellet gun? What is it? Is it like a staple gun? I don't want to get too crude here, but how do you put them in there?
It's like a big needle, a really big needle that you can pass the pellet through the needle.
Whoa.
But these are like even smaller than Tic Tacs. They're pretty small. So,
Okay.
It's really, honestly, I think it's probably what I would choose. It's so fast and easy.
And then you don't have to take gels and pills.
4 shots every week or day or every 2 weeks. Exactly. Or
so you have
remember to take pills.
And it's about every 4 to 6 months.
It is. Right.
Okay, so pellets, that's option one.
Option one. Then we have the shorter acting shots. So these are just liquid testosterone, which you can get done every 10 weeks if you have it done in a clinic. It's a little bit longer acting, but it has some special risk factors, so it has to be given by a nurse. Then there's really short acting, which is like 2 weeks. And so you just say, all right, every 2 weeks I give myself a shot. That's it. Some people prefer, though, the more natural rhythm of what your body would do. And so they try to copy that. And so they microdose testosterone. We call it micro, but it's not really. It's just a lower dose. But they give it every morning.
Every morning, just like your body would have
Just like
done.
your body would. You say, all right. But some people really hate shots, right? They just don't like the
That
idea.
seems
of it.
like a wee bit of a commitment.
Yeah, right? To wake up
Every
every
morning, I'm going to give my shot.
Yeah, but we say, hey, you know what? Diabetics do it every day.
They
you
do
know
it
what?
many times a day, yeah.
If you want to do it, this is up to you. This is where I can't tell you it's better or worse. No one has been able to prove that these are better or worse than the other. What they can tell you about, though, is the roller coaster effect. So, for instance, in the 2-week shots, let's say, everybody's body's a little bit different. And we assume, well, 2 weeks is just the standard. But some people are going to really drop off in that day 10 to 14, and they really just don't feel great. And they're like, man, I'm right back where I started. I hate this. And so then you're like, well, we can either shorten the duration, increase the dose, but that
Try to get you through to your next shot without having
right.
symptom recurrence.
But you're going to have more of that up and down. If you do daily shots, at the end of the day, you're going to be really tired. If you do the 2-week shots, at the end of the 2 weeks, you're going to feel really tired.
The longer acting ones sound better for all that. Right. I like your pellet preference.
Yeah.
Do the pellets disappear, or do they have to get taken out? They just dissolve after 4 to 6 months.
That's it. That's right.
Okay, I don't like shots at all, Doc.
Okay. So here we go.
I'm not putting a needle in me. You're not putting any pellets in me.
That's right. I understand
what else you got up your sleeve?
We've got 2 other options. So one is creams. I personally don't like these.
Aren't they messy?
They're messy. They can cause
Patients have told me they're messy.
They can cause skin irritation. And the biggest risk is the risk of transference. So what that means is, hey, I wake up, I put my gel on, I forget to wash my hands really good. What if I go have my grandkids over that day? There are cases where this causes early precocious puberty.
Oh, transference to another
person. Yeah.
Because
So
there's
it's dangerous.
on your hands.
Right. Women weren't meant to have the same testosterone levels as men. So even if I just go and hug my wife, give her a gentle touch on the cheek, a kiss
with your
goodbye,
testosterone-infused hands. Yeah, okay.
A couple
Maybe
weeks later,
not.
Wife's got a mustache, and you're like, hold on, what's happening?
Does it wash off easily?
It is supposed to. I haven't actually read the instructions to see how well you're supposed to wash, but it's a risk. So
where do you put it on your body?
They have different options. Certain ones are, say, the inner thigh, and then other ones say the upper outer arm.
And is it like thick, creamy, like Vaseline,
kind of
petroleum jelly?
I don't think
or
it's
is
quite
it
that thick, but it is, it is.
I have
like
heard
a
it's
foam,
messy.
But it's messy, yeah. So I usually don't prescribe those. I have a couple patients who have been on them for 20 years and they don't want to change.
And so
That's
it's
fine.
good. But it seems like it might be hard to dose, too. Do you get the
is.
right amount?
No, you're spot on. That's the thing. Some of them have like a pump actuator dispenser, but it's like maybe it's a little less some days and a little more other days. And maybe the absorption's a little bit different because I was at the beach yesterday and I was slathered with a sunscreen still.
Right.
So they've done plenty plenty of studies to show that dosing is a lot more variable. And because of that, maybe your outcomes are a lot more variable.
So you have transdermal methods.
That's right. And then
then you said there's pills now.
There's now some pills. So the biggest hurdle we have with this is insurance coverage and then just remembering to take the pills. So again, you have to take these twice a day. And with that, if you forget to take it because you're like, I don't know, I already have 5 other pills or I've just got a busy life, you're going to have that same roller coaster effect that's even worse. But if you don't want a shot, it's your option.
I don't think I've in my life prescribed pills because I've been doing this a little. I've sent people to you,
right?
And I have a couple of people on those gels, so that's why I know about that. I don't think I've done any pills yet. They really haven't been around long.
No, they really, just in the past 2 to 3 years, they've really finally gotten approval. There was an older oral version, but it had a lot of liver side effects, so we had to watch it a lot more closely, and they recommend against those now. But the new ones are safe.
So what can people expect about resolution or at least improvement of symptoms? Is it that afternoon, next week, a month later? And can they expect erectile dysfunction will be better? Can they expect energy levels be better? What can they expect about the response?
So usually it is pretty quick. I mean, people will really notice within a day. They say, wow, I've got more pep in my step. I feel more drive. The erectile dysfunction it's a hit or miss. So we can't promise it's going to get better, but there are studies that say yes. There are some studies that say no, because again, you can have all those physiologic problems too, blood issues, blood flow issues, nerve issues. So there's a lot more of a complex issue.
It's not just testosterone, as you mentioned earlier, but it could help. It's possible.
Help. Right. But things like weight loss, they're going to take months. But I have seen tons of patients who've come into my clinic, they get started on testosterone and they'll say I feel better. And I look at them, I'm like, have you lost weight? And they're like, 30 to 50 pounds. I'm like, whoa.
Yeah.
Do we notice that all started right when we got on the testosterone and we were able to, maybe they're not as, surprised. They're like, oh, I don't know. I didn't feel a huge difference. I'm like, look at your body. You're 30 pounds lighter right now.
Wow. What about other side effects? And side effects is a funny word we use. All medications cause a bunch of effects. Some of them we want, some of them perhaps we don't. You said the risk for prostate cancer isn't really as high as people thought.
No. In fact,
at all.
At all. It's really not been validated. You are required to check a PSA before and during treatment because you do want to follow it because, like we said, any man who's of this age group can get prostate cancer, specifically men over 50. But there is no data that says that prostate cancer gets worse while on testosterone.
Okay.
So that's important. Other side effects, though, that we do have to watch for. So we check people's liver enzymes, especially mostly because of that older formulations that did have more liver side effects. I've yet to see anybody have any liver issues yet. But one thing that is very common, but really not that dangerous, is an increase in their blood count. So if somebody came in and they actually had a low blood count and you put them on testosterone, you can expect that to go up. But if somebody was already at a pretty normal blood count, you might find that they become polycythemic. Their blood gets a little too thick.
I do have a guy whose hemoglobin's pretty high, abnormally high, and we think it's his testosterone.
Yeah. But you know what's interesting about it, though? And I've gotten into a debate about this with hematologists who are like blood doctors, right? So all the studies about the dangers of this high blood count, none of them are in patients on testosterone. They're only on patients who have had other blood disorders.
They have high blood counts for other reasons.
Right. Yeah. So other issues. So there's a big debate at the big, urology conferences where we talk about testosterone.
Should we worry about it?
Should we even worry about it? We kind of have to just because, you want to protect patients and make sure nothing happens. And so it's as easy as this. If somebody has a hematocrit over 54, we just say, great, donate blood. And if you can't donate blood to the Red Cross, then we say, okay, we'll do phlebotomy.
Yeah.
We'll just take the blood.
We'll drain you a little bit.
We'll drain it.
We'll drain it. That's it. No biggie. No biggie
at all.
We're not going to talk about treatments for ED today because listeners, I'm going to refer you back to that episode from a couple seasons ago. So we're not going to get into that, but just know there's plenty of other treatments for that we've talked about in more detail about erectile dysfunction. So before I let you go, I want to do two more things. One, could you just briefly talk about preventive health? Is there anything people should do to prevent urologic problems in men, their sexual health, their all of it?
Amazingly, and of course, like any good doctor's podcast, with all of these things, prostate cancer, with low testosterone, you want to cut down the body's inflammation, you want to stay healthy. So you want to not become obese. So that means eat right, exercise, don't smoke, don't drink to excess. All the things the doctors have been repeating to us over and over and over again. It's live a healthy lifestyle. That's really the main thing you can do. Another interesting thing, though, about testosterone is sleep. So sleep actually plays a 10% role in about normal testosterone. So you can actually take somebody who, for instance, works night shifts, and I've seen this, and it throws off their circadian rhythm, their testosterone's low. They can expect a 10% increase if they were to go back to getting a good 8 hours of sleep. A good night's sleep.
That's really good tip. So the healthy living stuff, I just wanted to touch on that just so we make sure that that's always important. And you're right. We've been doing this podcast now for 5+ years, and it comes up a lot. I've yet to hear any of my guests say, I recommend you start smoking. Nobody's ever said that yet. Okay. As I said at the beginning of this show, this is a topic that maybe people find uncomfortable to talk about, but I hope you have realized by listening to this that it's actually a topic you can talk about, have a little fun with, and there's really good science, and there's really good things to be done, men and your partners. So don't feel bad about talking about it. And doctors out there, make sure you ask your male patients about their sexual health. Okay, Travis, if you could leave us with a message, what would your take-home points for our listeners be?
Well, I would say kind of like what you just, I would re-emphasize what you just said, and that would be normalize men's health. Men should be more proactive. They should come to the doctor, get checked out, because there's a reason that married men live longer. It's usually because their wives drive them to go get them.
Have you ever seen that billboard? There's a billboard that says, many men are going to die of being stubborn. And then somebody had spray painted, no, we won't.
Yeah.
So men are a little bit stubborn. That's a true statement. That's been validated that men seek out healthcare less. The average healthcare user of healthcare is a woman.
Right. And I think that it's just, if we could normalize healthcare a little bit and we could make people feel comfortable coming to the doctor and asking the questions that they really have instead of the internet, you'll get true answers and you'll get reliable answers and you'll get health. Yep. You'll get good health. And good
Go
care.
see Dr. Pagliara, everybody. You don't have to get all your information from the internet. So Travis, thanks for being on the show today. It's been a great episode.
Thanks, Dave.
Great to have Dr. Pagliara back for his second round on the podcast. Listeners, thank you for joining us. The holidays are the best medicine, so we are going to take a break, and we will see you again for our next episode in early 2026. Happy holidays and Happy New Year. And as always, be healthy and be well.
Thanks for listening to the Healthy Matters Podcast with Dr. David Hilden. To find out more about the Healthy Matters Podcast or browse the archive, visit healthymatters.org. Got a question or a comment for the show? Email us at healthymatters@hcmed.org or call 612-873-TALK. There's also a link in the show notes. The Healthy Matters Podcast is made possible by Hennepin Healthcare in Minneapolis, Minnesota, and engineered and produced by John Lucas at Highball. Executive producers are Jonathan Comito and Christine Hill. Please remember, we can only give general medical advice during this program, and every case is unique. We urge you to consult with your physician if you have a more serious or pressing health concern. Until next time, be healthy and be well.